You're watching ACC Update on CardioSource Video News.
Coming up, abounding challenges face cardiology on the advocacy front. Payment reform, tort reform, private practice protection, and regulatory changes are just the tip of the iceberg. Find out how you can stay informed and get involved. We'll also take a look at a new drug used for the treatment of patients with atrial fibrillation. What is the college's position on the anti-clotting drug dabigatran? And how does it stack up to warfarin? And later in this program, ACC's CEO Jack Lewin will join us to share some simple, cost-effective tips that can have big impacts on CV care. Stay with us.
From the American College of Cardiology in Washington, D.C., this is ACC Update.
Welcome to this edition of the ACC Update for March. I'm Lisa Fletcher. Cardiology faces a number of challenges on the advocacy front over the next year. Key issues include payment reform, delivery system reform, tort reform, health IT adoption, and regulatory changes. Continuing to advocate for repeal on the sustainable growth rate formula, testing and developing innovative new payment models, and participating in ongoing discussions around what constitutes an accountable care organization are just a few of the core goals for the college's advocacy team. Also important, assisting with the next phases of the Federal Electronic Health Record Incentive Program and strengthening relationships with the FDA on patient safety. For more on the ACC's advocacy agenda, visit cardiosource.org/advocacy. The ACC Political Action Committee also offers critical opportunities for U.S. members to ensure the voice of cardiology is heard on Capitol Hill. For information on the PAC, go to accpacweb.org. The American College of Cardiology Foundation, along with the American Heart Association and the European Society of Cardiology, have released an update on the use of the new anti-clotting drug dabigatran in the treatment of patients with atrial fibrillation, or AFib. The update says dabigatran is useful as an alternative to warfarin for the prevention of stroke and systemic thromboembolism in patients with paroxysmal to permanent AFib and risk factors for stroke or systemic embolization who do not have a prosthetic heart valve or hemodynamically significant valve disease, severe renal failure, or advanced liver disease. Previous recommendations for warfarin still stand. This new update is an addition to the focused update on the management of patients with atrial fibrillation that was released back in December. At that time, dabigatran had not been approved by the Food and Drug Administration. For more information on the update, as well as the latest AFib news, visit the ACC's AFib community at afibprofessional.org. As part of the ACC's efforts to improve care for congenital heart disease patients and move the overall prevention agenda nationally, the college recently hosted a meeting with the National Heart, Lung, and Blood Institute and the Health Resources and Services Administration of HHS to promote standard coverage of pulse oximetry for newborns as a preventative service. Pulse oximetry is useful in detecting CHD before hospital discharge in otherwise well-appearing newborns. Standard coverage would accelerate early detection at very modest cost. More information on CHD can be found at cardiosmart.org. In addition, the ACC's annual scientific session in New Orleans is featuring a wide range of educational opportunities for CHD and pediatric cardiology specialists as part of the Congenital Cardiology Solutions 2011. The ACC recently joined efforts with Operation Medical Libraries, a grassroots organization that collects and distributes medical textbooks and journals to war-torn countries. The organization works with American medical schools, hospitals, physicians, and the U.S. military to help physicians and nurses in developing countries who are working with updated information, which means better care for patients. Cardiovascular professionals attending ACC 11 in New Orleans are encouraged to drop off gently used and current textbooks to the international section of the ACC booth. The college will then make a one-time shipment overseas of the books collected. For more information on how to participate in the OML program, visit the International Center at cardiosource.org. When we return, we will be joined by ACC's CEO, Jack Lewin. Stay with us.
Efficiently and accurately report cardiovascular services and procedures with the new CPT guide for cardiovascular coding. Available for shipping this month. Visit cardiosource.org/CPT. Explore various imaging modalities and cutting-edge technologies at the 33rd Annual Recent Advances in Clinical Nuclear Cardiology and Cardiac CT, featuring case review with the experts, May 5th through the 7th in Washington, D.C. Visit cardiosource.org/nuclearcard for more details.
I'm here with ACC CEO Jack Lewin to talk about some simple, low-tech, cost-preventive strategies that can have a big impact on cardiovascular care. Dr. Lewin, thanks for being here.
Thank you, Lisa.
So what are some of these preventative strategies that cardiovascular professionals could be working into their practice that are simple and low cost?
Yeah, well, you know, I'm remembering back when I was still a medical student, having the privilege of hearing the famous Proctor Harvey speak. And he recommended, even back then, you know, he said he could diagnose 90% of the people coming in with cardiovascular disease using a good history, a good physical examination, and that would include, you know, auscultation of the heart, listening for murmurs, which is sort of a dying art, checking pulses, you know, and all that you can learn from diagnosing from pulses, and a 12-lead electrocardiogram, a chest X-ray, and then a few simple lab tests, lipid tests, kidney testing, and electrolytes, for example. With that simple 5-step approach, he could diagnose the vast majority of people coming through the door with heart disease. Now, you know, why has all of this become increasingly a dying art, where we use technology rather than those foundational skills? There are things that can be done today in this era of healthcare cost containment. And in looking at the third world, the emerging world, where in fact we're not going to have anywhere near the number of cardiologists we need, what can we do at lower costs, simple steps, to diagnose and treat, or early diagnose or treat a lot of cardiovascular care conditions? And there are some basic things we should remember.
What are some of the things they can do?
Well, one of them is, you know, we know that aspirin, 5 grains of aspirin taken immediately upon symptoms of a heart attack, if the patient's having a heart attack, it can be a life-saving medication. And you know, in my wallet here, there are new products on the market these days. Here's something that I saw. It's amazing. This is the size of a business card. It's 5 grains of aspirin. Okay, I probably don't need this, but the person next to me in the airplane will. And I've been there doing the CPR for 2 hours on a plane on the way to Hawaii, and on other plane experiences. This is an interesting thing, could save a lot of lives. And you know, you get onto an airplane, they have Tylenol, and nobody seems to have an aspirin. So there's a simple step that could save a lot of lives for people, particularly people at risk. Pulse oximetry. The ACC is promoting that this be added to by the Preventive Services Task Force as one of the things that we provide routinely for newborns. Many kids with congenital heart disease, the disease is frighteningly apparent, but some kids it's not until you know, months later in their lives. With pulse oximetry, you can very cheaply have a means of diagnosing kids who really ought to be worked up for congenital heart disease. So that's a simple kind of thing.
And you were telling me in India they're able to do it for $2 a kid, right?
Yeah, like a little over $1. They're doing it routinely in parts of India. So why don't we get with it here in the United States? I mean, that's important. You know, ankle brachial index, the ABI, measuring the blood pressure in the arm and the leg and comparing those, is one of the most sensitive ways of diagnosing peripheral arterial disease, which itself, if detected, means you have coronary artery disease and a very high risk of myocardial infarction. So here's another test, very simple, part of the physical exam that just isn't done. People don't want to do it. You know, measuring the body mass index, the BMI, for every patient coming into the office needs to be done routinely, associated with diet and exercise counseling. Just a basic thing that very, very often, we know from talking to people who are using the Pinnacle registry, it isn't routine.
And what about talking to patients about smoking?
Unbelievable. The Pinnacle registry has demonstrated to us that 80% of the time, we're forgetting to ask whether the patient smokes and provide counseling. And in many cases, when we go back and query the doctors, they're saying, oh, well, this patient's a consult. The primary care doctor's been handling that. Then you ask the patient. Nobody bothered to ask me whether I'm a smoker. Now, we can't afford, 4 out of 5 times to forget that. So simple things can make a huge difference in healthcare, and there are many more that I could add to this list. But we've got to go back to Proctor Harvey and remember that there's a lot we can do with history and physical exam, 12-lead EKG, a chest X-ray, and some simple lab tests that will tell us a lot that we are oftentimes using very expensive technology to try to understand.
So Proctor Harvey and others have these very simple strategies that obviously work. Why aren't they being integrated into practices right now?
Well, the Proctor Harvey stuff was the good old days, and the technology that we have today is really very exciting. We love these tests. We like to use them. I mean, you can see the heart with, with all these new diagnostic approaches. I mean, echo being probably the least expensive and least certainly not invasive. But these are exciting things, and we're doctors, and we like all this stuff. And in fact, it's interesting to to see the CT and the MRI, and have the echo, and have the nuclear scan.
But shouldn't those be the things that validate what you as a doctor have already discovered, based on your knowledge as a cardiologist?
Well, that's right. But I mean, these tests are wonderful innovations, and they're part of the reason that we have a 30% reduction in morbidity and mortality in the last 10 years. I'm not devaluing those. I'm just saying, let's use them when we need them, and let's use the simpler techniques, including history and physical, for example, when those would lead us to the diagnosis just as fast in many instances, and we can confirm it. But nonetheless, there's a lot that we are somehow we're jumping to technology because it's part of the way we get trained these days, rather than thinking about these foundational skills, which are still very important.
Dr. Jack Lewin, always a pleasure having you with us. Thanks for being here.
Thanks, Lisa.
All right, and join us next month for the ACC Update. I'm Lisa Fletcher.